Hello, everyone. Thank you so much for joining us this afternoon. For those of you who don't know me, my name is John Lin. I'm a urologist here at Sunrise Urology, also your humble host of the Thriving Urology Practice Facebook group. We are delighted to have Mark Painter here today to give us an update on 2021 E&M changes, coding and billing for bladder cancer, Modifier 25, as well as some telemedicine updates. Today's program is sponsored by FearGene, and I am very pleased to have Jessica Pompa, who is part of the market development team for FearGene, and she has a few words for us before we begin.
Thank you, Dr. Lin. Thank you for setting this up. I'm honored to introduce FairGene as today's program sponsor. To introduce FairGene, FairGene is a privately held gene therapy company. We're dedicated to providing innovative solutions for patients with bladder cancer through science and patient care. We're also committed to urology and providing valuable resources like today's program to you. As you read through some of the program disclaimers, I would like to take a moment and introduce Mark Painter. For many of you, you know Mark Painter. He is a managing partner at PRS Consultants. He's worked throughout the country to educate and consult with urology practices in the areas of billing, coding, and reimbursement. And we're very honored to have his expertise today for the program. So without further ado, Mark, take it away.
Thank you very much, Jessica, and nice to join you, John, again on the Thriving Urology Practice. So today we've got a few things to cover relative, again, to all the changes that are upcoming within Medicare and beyond. So I'm going to go over today a little bit of a review with telehealth, as we're starting to see, at least in Colorado and a few places around, the reaction to the pandemic, shutting things down a little bit again, may see telehealth ramp back up. So want to cover some of those changes, both during the public health emergency and beyond. Then talk a little bit, as John mentioned, about the E&M coding changes that are coming up for 2021. Briefly touch on proper use of Modifier 25. And then close out by talking a little bit about TURBT coding and a couple of issues that we've noticed still resonating out there as problems. And close out with some ICD-10 and a little bit of a discussion around installation, billing, and coding relative to treatment of bladder cancer. So we'll start off with telehealth across the board. And it, of course, the most important part of what we've seen with telehealth is Medicare's reaction during the public health emergency. And you probably all know by now that we do have an extension of the public health emergency until January 21st of 2021. I can tell you with a number of my discussions across the board with folks in Medicare and those that are close to Medicare, and certainly watching the final rules that have been coming out and hearing some of the discussion around the imminent release of the final rule for 2021, it really does look like the public health emergency will likely be extended one more 90-day tranche again. So that would put us all the way into March. But right now, what we know for sure is that these rules are going to be in place until January 21st. And those rules allow you to bill office visit codes, your 99201 through 99215 to your patients, as long as you have an established audio and visual connection. And as you put those out the door and reporting them to Medicare, you are going to use place of service 11. So that's your office, regardless of where the patient is or where the physician is. And I shouldn't say regardless. Obviously, if they're in a hospital setting, you can't use the office visit codes if they're an inpatient. But for any of your outpatient services, you can use that and append that modifier 95. And hopefully all of you are well aware of that and well versed in providing services via telehealth. Because again, it looks like we're going to step up that for the next little, or the next few months at least. And then a couple of the things that I did want to pass on to you that specifically as Medicare started taking a look at appropriate billing with telehealth that you really want to be careful of. So number one is if you are unable to establish a visual connection with the patients, the interim final rule was pretty clear that you should not report the E&M codes, but instead report the telephone only codes, the 99441 through 99443. Those codes are available and billable within the public health emergency and really should be used if all you can get is telephone connection. You can't get the visual connection. If you've got kind of that in-between visit that you had visual, so you had a video connection with them, but you just couldn't sustain it through the whole period because maybe they didn't have enough bandwidth or it kept dropping out. For those, because you've got a partial video connection throughout the visit, document that and go ahead and use the office visit codes. So that's one of the things they're looking for. And then the second thing that you really want to make sure that you do each and every visit is document a verbal consent for the telehealth interaction. You can definitely get a blanket statement written and secured for the entire year. That will help, and you should get that overall, but get a verbal consent for each and every encounter. Go ahead and build that into your templates. From the private payer side of the equation, we're really seeing them follow what Medicare does. Now, they're a little bit off on their timing, and what we've seen across the board are your bigger payers like United and Aetna and Cigna, those folks that have Medicare Advantage plans and a large footprint across the country. They are following the public health emergency as far as allowing telehealth and an expanded version as Medicare does. But they're also a little bit off calendar wise in that they tend to focus on calendar quarters. So what we saw is a lot of the payers would have an expiration of the telehealth rules that was coinciding with the last day of the quarter. We saw this in September that United and Cigna had originally targeted their telehealth service coverage under the public health emergencies to end either on October 1st or soon after the 1st of October. But letters went out right towards the end of September telling us that they were going to extend them to the end of the year. So they're really trying to look at what's happening in the environment and hearing information from CMS, and they are truly following kind of Medicare's lead when they extend. But they are providing a little bit of variation from Medicare, not great variation, but as far as looking at co-payments and whether they're going to cover those or not, and whether or not they're going to accept the place of service 11 or 02 or modifier 95 GQ or GT, those vary a little bit from place to place and from plan to plan. So you do want to keep an eye on your payers. We recommend that you keep kind of a spreadsheet of where each of the payers are and where the reporting requirements are for each one of your payers. Watch their websites because they are also dealing with stay-at-home orders in various places, and the stellar support that they give physicians is even greater now. And I'm of course being sarcastic. With everyone staying home, it's a lot harder to get a hold of the private payers across the board. Now, when we look at the eventual end of the public health emergency, we've got at least a window as to what Medicare is thinking. Medicare really did come out saying they were very supportive of telehealth services. They found that their physicians and their patients, their beneficiaries, did like the experience of telehealth where it fit within healthcare. And I would say the same is true of many of our physicians that we've spoken with over the years. It has a place. It doesn't take the place of face-to-face visits, but it has a place in some circumstances. So Medicare is really trying to expand what they can in telehealth, even after the public health emergency ends. And to that end, they expanded the number of services that are included on the covered telehealth service list uh, for the public health emergency, and are telling us in the proposed rule that a lot of those services that were added for the public health emergency are going to be or continue to be covered through the end of 2021. They added a new category of services that they're going to test. A lot of those services don't really play a big role in urology, but there are a couple that are interesting. And one of them is the use of telehealth for emergency department visits. This is kind of interesting overall, I think, for urology practices, is it in that if you are able to establish an audio-visual connection to an emergency room, you would be able to bill an emergency room visit because the patient would be in a Medicare-approved facility, and that allowing that to occur may allow you to provide some coverage to patients that are not maybe readily available to your office or to an emergency room that you can get to. So that looks like it's a little bit interesting, might be a way to expand your reach for your practice and something that you might explore. Now, the other couple of things that are interesting in the proposed rule is that they are going to extend the ability of the physician to provide video supervision for their practice. And this is a lot of this is really related to the fact that Medicare wants to make sure they can provide clear and easy access to healthcare for all of their beneficiaries. And allowing this would mean that if you had a remote office that you were working with, or for whatever reason the physician couldn't get into the office, that if they had an audio-visual connection with their nurse or their staff, they could go ahead and provide services like LHRH injections, those types of things, and bill them incident to using the video supervision. Obviously, you want to make sure you can provide things that are medically safe in those environments, but the billing pathway is there. They are also, as they're moving forward, clarifying some rules as to how you can report telehealth services as long as you're in the same facility. Again, after the public health emergency right now, you can do this. They're extending that after it's all over. And we're seeing an expansion and a really targeted expansion of CMS trying to provide coverage and payment for communication technology-based services. You know that before the public health emergency, we were talking about G2010 and G2012 as far as check-in visits. We've got portal visits that we can charge for. And they're also trying to expand the coverage for remote patient monitoring, which we've got some new technology floating in from various sectors to allow us to maybe do remote monitoring of some of our patients in urology. Now, we're waiting for some additional clarification for a few things in the final rule that may or may not make this valuable to urology. And in the end, I think the piece of this that is probably the biggest hangup for most folks is the reimbursement level isn't quite at a point where it makes it an easy add to the practice. But I would argue that it does give patients who are now experienced with telehealth or with remote service provision through various avenues, a way to get in touch with your physician and a way for you at least to get paid for some of the things that you used to give away. So there may be a number of ways to incorporate telehealth moving forward. We may have to get creative on that because the financial piece isn't quite where we would like it to be. Now, when we look at the other side of the coin as to what Medicare is not going to do after the public health emergency or what they're not going to cover, one of them is by choice. They originally in the proposed rule said that they were not going to continue to cover the telephone only services after the public health emergency ends. I can tell you that in the 60,000 comments that Medicare received, based on the proposed rule. There was a lot of support for telephone-only coverage, so the final rule may change that position with CMS. And then CMS elected not to extend telehealth services to new patients. That one's going to be tougher to see change, that when we don't expect that to change. But the big one, and I think the biggest block for telehealth moving forward, is by law, Medicare or CMS is not allowed to cover for services provided to a patient who is in their home unless it's under the public health emergency. So it is going to take an act of Congress to make that available. CMS in their communications is all for it. But again, we need action by Congress to actually make this happen. So we'll have to wait and see if there's anything that can be done in this lame duck session or then beyond, as we see what happens with the presidency and with the legislator as we're moving forward. So we're waiting on that. Moving now to talking about the 2021 E&M proposed changes. So I do want to clarify, first of all, that the changes I am talking about the codes and the actual descriptions and the documentation requirements, those are changes that were made in CPT. The CPT manual has already been published. Those rules are out there. According to HIPAA law, all of the payers need to adopt these changes by January 1. So these changes are going to be in place for all payers. They are changes that only affect the office or outpatient codes. So that would be the 9920 series and the 9921 series of codes. CPT has deleted code 99201. So we will now, for new patients, have 99202 through 99205. I'm going to get that taken down off my screen. I thought I had that on mute, but anyway, sorry about that. And then we will have codes 99212 through 99215. Code 99211 still exists. It's still a nursing visit, so it didn't really change in its description. The requirements for documentation, though, has shifted quite dramatically under the new rules. Number one, they have changed the rules so that we no longer have to worry about the amount of history and physical exam that are collected when we select a level of service. The level of service is going to be based solely on medical decision making or on time, not on both, but one or the other. Now, when we look at all of these changes, as we see what's coming down the pipeline, this doesn't mean that you don't have to document history and physical. What it means is that you don't have to worry about 10 review of systems or a past medical family. You must document only what's medically necessary. And that is true of the physical exam as well. So gone are the requirements for 8 systems when we start for the new year. And I should say gone, but for office visits only. We are still going to be required to follow the existing guidelines of history, physical, and medical decision-making for inpatient visits, observation visits, nursing home visits, consults, if you're still using those, are still going to be under the old rules requiring history, physical, and medical decision-making. I don't have time today to really drive into the nuances of medical decision-making. I would encourage you to do some reading, get some training on those changes. Look at the detail there. I think it's a great opportunity for you to really take a look at your office flow across the board. But you do want to try and do that. I may give you a couple of examples here and there. But I also wanted to let you know that the definition of time and the ranges of time have been changed for 2021. So now you are no longer required to spend over 50% of the visit in counseling or coordination of care. You can bill time for any visit you so choose. I don't recommend it still, because the medical decision making and the efficiencies you can obtain based on your medical decision making are actually more relevant to most of your patient care. But if you so choose, you can use time for everything, and you are allowed to count all of the time that you spend that day that is distinct in E&M service, whether it's face-to-face or not, as time related to the E&M code. So obviously, you can't include the time you spend inserting a catheter, but you can include the time you spend preparing for the visit, the time you spend with the patient, the time you spend with the family, whether or not the patient's there, the time you spend in documentation after it's over, the time you spend trying to get coverage for the patient. All of those can be added together for the overall time. And if you are charging based on time, the time that you spend overall should be documented right now only on the overall time that was spent, and then include the accomplishments during that time frame. Now, from a Medicare specific side, we have a new code that is going to be introduced. Again, this was part of the proposed rule, and we'll see how it actually comes into play. But the GPC-1X is a code that is used for any visit in which the patient is being seen for a problem that requires ongoing care. For urology, that's a lot of what you do: BPH, overactive bladder, incontinence, and any of the cancers you're treating. Those require ongoing care and a relationship with that physician. So a lot of what you do, you're going to be billing an E&M code plus this GPC-1X in every visit. And that GPC-1X does have work of RVUs and a payment associated with it. That's going to be anywhere between $14 and $20, depending on where you live. All right. Another piece that you do want to look at, an AMA change, is the addition of the new code 99417, which is for really the prolonged E&M time, those visits that you bill based on time. This code can only be added to a 99205 or a 99215. Medicare's definition in what they published was that you have to spend at least 15 minutes in order to report this code. So that would be 89 minutes with a 99205 and 69 minutes with a 215. And if you spent 30 minutes, you could use that code twice in addition to your level 5 code. You can no longer, because of this new code, use the existing prolonged service codes, but that is available to you. Now, again, going back to where Medicare is looking at the impact of the E&M codes, the AMA RUC committee recommended, and the recommendation was accepted by CMS to change the values, and they actually increased the values assigned to the evaluation and management codes. When those increases are taken into account with budget neutrality and all of the other changes that were made within the RBRVS, or the Medicare fee schedule, it looks like urology is going to come out with about an 8% increase overall. But that's really looking at urology as all urologists as a package. So it's not going to affect everybody the same way. For those of you who do most of your practicing in a hospital setting, because the evaluation and management code change was an increase, and because it has such a high volume within Medicare, Medicare is going to, or projected to, lower the conversion factor by 10.6%. This means that the services that you provide in an ambulatory surgical center, the services you provide in a hospital, and a few of the services that you provide in the office are going to be paid at a lower rate next year. So you're really going to have to take a look at your own practice to see whether or not that impact to you is going to be 8% or a little bit higher, or down in the 2 to 4% range. So everybody's going to be impacted a little bit differently depending on where you practice and the services that you provide. So again, taking a look at what these impacts will be and planning for those in your practice, taking time to really understand the new E&M changes and the new rules relative to medical decision making is going to be very important because we're going to get a whole new set of guidelines on how to bill appropriately and where the reviews and audits will come into play. So I'm going to pivot now and talk a little bit about Modifier 25. Modifier 25 is, of course, a fairly common modifier within the urology practice because of the services that you provide. That Modifier 25 is your ticket to being paid for an E&M service provided on the same day as a 0 or 10 or 90-day global procedure, as well as some of your injection codes. And the Modifier 25 ends up on the OIG identification list or the investigation list year after year because it is misused quite a bit. So I just want to kind of remind you all some of the specifics of that Modifier 25 and what you need to do to make sure you're documenting appropriately and using it appropriately. So number one, in the definition of the Modifier 25 are two really key issues. The one is that the E&M service is significant, and the second is that the E&M service is separately identifiable. And so let's break that down a little bit. As I've gone through a number of audits with private payers and with Medicare, this has been an argument issue across the board. Significant is a key phrase that you need to think of kind of at two different levels. One, it has to be significant in that the service you're providing is medically necessary for that patient on that day. The second, it has to be significant in that it is not part of the global for the service that you're billing or for the other services that you provide. So if you look at the global process overall and the definitions there, making sure that a patient is healthy enough and hasn't reacted to maybe an injection or something that you've done in the past, that's part of prepping the patient for a service that day. Of course, anything directly related to the provision of the procedure or service is included, and then telling the patient what they found and how to recover from the service you provided is all included. What's not included are services that you provide looking at other data or other information to help decide if they need a service, and taking information that you've gleaned from the service that you've provided, as well as other information from some other information that you've obtained from the patient or from other areas, and talking to the patient about what's done next, making decisions about what's going to be next in their treatment pathway. So those are all important things to make that significant. The separately identifiable piece, when you consider that most of the insurance company auditors are really not working for you, but for the insurance company, and they're not as familiar with urology as you are. They're not going to be able to go through a similar document and pick out what's separately identifiable as easily as I would or you would. That doesn't mean it can't be billed, but it does mean you're going to get more questions about it. So what I would encourage you to do is physically separate procedures or services from the evaluation and management service that you document that day, making it much easier for those doing the reviews to see that it was in fact significant and separately identifiable. And then I want to reiterate something that it kind of bounces around. You are not required to have a different diagnosis for the E&M service for the other procedures that you do that day. Now, that does not mean that your payers aren't going to request records. They are. They're requesting records quite frequently for those services that are provided on the same day and billed with Modifier 25. So it's not required, but you are going to see some requests for records, and you are going to need to have the supporting documentation to show that it was significant and separately identifiable. So now moving on to talking briefly about TURBT coding. most of you know this, and so it is. I believe review for almost all of you. Size matters. That's an important piece that's here. The auditors that we've dealt with across the board from private payers are going to first look to your operative note to see if they can determine that you have resected or fulgurated a tumor that meets the definition of the code. So as a physician, if you document the size of the tumor before you resect it or remove it, they are going to base the coding based on the largest tumor that is removed or lesion that is treated on that particular date. So make sure that's in there. If they can't find it, they're going to next pivot to look at what goes to pathology. That's something they can use. It usually is a size smaller than what would have been in the operative note. If it's not in either place, they're going to assume that it was the smallest of all the tumors and drop you down to the lowest code. So those are important things to look at. Now, the other thing that I do want to point out, and of course, you cannot add the size of the tumors. It's based only on the largest tumor. The other thing that I'll point out is that the basics of treating bladder cancer and treating lesions or tumors in the bladder is that you're going to want to find out what the underlying pathology is to decide what's next. So any biopsies sent to pathology or taken from the area before it is fulgurated, that is included as part of the treatment procedure. What is not included are biopsies taking at other parts of the bladder. So if you have clear documentation supporting a biopsy of the bladder in an area other than which is treated, you can report the 52004 with a 59 modifier or an XU modifier for those cases. Moving quickly now to talk about a little bit about ICD-10 coding and some of the issues that we see there. We do have some issues that we want to make sure that you're very carefully telling the patient's journey and their story correctly when you're documenting this. And communication on the ICD-10 code is very important, not just for payment, but also for really showing the payer how good you are at what you do. So when we look through a standard patient, the first visit that they come into the office, maybe they've got gross hematuria and at that point in time, you decide to schedule them for a cystoscopy the next day. All you know after the conclusion of that visit is that the patient has gross hematuria. That is the correct diagnosis for that first visit. When you do scope the patient diagnostically and find out that they have a lesion in their bladder, you have a couple of choices. I think the best of those choices is to use the neoplasm of unspecified behavior. The unspecified behavior code means that you do not yet know what it is. This is as opposed to an uncertain behavior, which is an actual pathologic diagnosis that pathology looked at it and they couldn't determine if it was malignant or benign. Now, from an ICD-10 perspective, if you are clinically certain that that is malignant, you are absolutely allowed to select that as the diagnosis code. We're recommending, though, that you wait until the pathology comes back. It does not affect the payment. And in fact, the certainty that you have from visualization may not be there, but that is your choice. Now, once you actually get the pathology back, you do want to move to malignant neoplasm if, in fact, that is the diagnosis. That is now more specificity. And you also want to use the appropriate location. We're starting to see a number of denials for those folks billing with a C67.9 because that's a site unspecified. So use the location and the malignancy code. At this point in time, you've probably also determined that their gross hematuria was due to this malignant neoplasm. That code is a symptom and needs to be removed from the report or from your billing forms. So get rid of the gross hematuria symptom code, go to your disease state code. that Z51.12 that we have up there, that is a code that is an ICD-10 code, but actually relates more to billing. So that may be something that you assign to the billing department in your team approach to billing, to select that code and add it to the claim, because it is for only those visits in which you are providing a therapy like a BCG, an immunotherapy code. So we're starting to see this come up as some denials with some of the payers, but not all. But it is something you want to take a look at adding. Once you get the patient through the treatment phase and you're doing your surveillance cystoscopy, and the patient no longer has evidence of bladder cancer because it's been treated, you are now moving that patient to a personal history of malignant neoplasm of the bladder, and use that diagnosis for that patient until or unless they come back with a new tumor, in which case, again, you've got that same choice that you had in the beginning, whether going unspecified or malignant neoplasm. This time you might be a little more certain that it is a malignancy recurrence based on their previous history. So tell the story, move the patient through with diagnosis codes, and remove those diagnosis codes that are no longer as descriptive as the diagnosis that you're using. And then finally, I just wanted to talk a little bit about the installation codes that we have. I think most of you know that the 51720 is the most appropriate code for installation of an anticarcinogenic agent. It does have a global period of 0. So yeah, you may, if you're billing an E&M service, you will absolutely have to use that modifier 25 and make sure that your documentation supports that. And then, of course, you're going to want to report any drugs that you've purchased and delivered for the patient. Make sure that you're using the right J code. Make sure that you're using the right units. Make sure that that communication between the clinical and the administrative side is in place. And now you want to make sure that you are accurately reporting the NDC code in box 19. And if you are wasting any, or you're not able to use drug based on what is happening that day and how it's packaged and delivered to you, you want to bill on a separate line any of the drug that's discarded with a JW modifier. Now, very quickly, hopefully you all know that the places that we've seen issues right now with billing for installation codes are, number one, making sure that you're communicating the right number of units. But the second one is that NDC code. The NDC code, if you're getting a drug that's been compounded by another compounding pharmacy, is not the original NDC code, and you will need to check with your payers, your Medicare carrier in particular for a lot of these patients, to make sure that you've got the appropriate reporting codes from where you acquired the drug, or you could have some issues. So that's what I've got for you today in a fire hose of information, if you will. The information that I discussed was taken from the CPT book and the various proposed and interim rules that are affecting this year and next. So now I'll open it up. Any questions? And depending on what time we have, John.
Mark, Dr. Gupta asked, how could I bill if instilling 2 chemo drugs on the same day, such as gemcitabine and docetaxel?
So unfortunately, the way we're set up with the installation codes, we've had a few discussions on that 51720, and the fact that it really probably is not fairly valued, for one thing, because of the time that it takes and the fact that it can tie up a patient room. The practice expense value doesn't match. The other thing is, unfortunately, it has an MUE of 1. So you can bill the 51720 once. You could report all of the drugs that you use. I'm not going to say that that's going to be a simple process of getting it through, but the appropriate reporting would be 51720 times 1, and then the drugs listed separately in the units that you did for that particular encounter, and be prepared for some kickback from the payers as to why you're using both of those drugs on that day.
Sounds great. And for those of you who are watching this live, please feel free to write your questions in the comments, and Mark will try to answer them. It could be E&M, could be ICD-10, could be modifier 25, which a lot of you are not using or underusing, but if you do decide to use it, you want to make sure you're using it appropriately and not leave money on the table. I know one practice out in the West Coast got in trouble. They were fined, and now they completely stopped using modifier 25, which is a shame. If you know the rules, you should be able to confidently use modifier 25 and not leave any money on the table.
Agreed. You should definitely accurately report what you're doing. It's your time, it's your skill, it's your product that you need to report each and every time. Making sure you've got your compliance plans and your training in place is really all about making sure that you are accurately and adequately getting paid for what you provide. I mean, that's the way the system works.
And Dr. Wallen asked, what about post-op mitomycin C? Are we still required to do it in the PACU and not in the OR so that you are getting paid for that intravesical installation?
Unfortunately, the bundling edit is still in place, that the 51720 cannot be billed during the same encounter with a TURBT code, any one of them. So a lot of that has to do with the fact that, flushing and filling the bladder is part of a cystoscopy and a treatment code. I think it's a bit short-sighted in how they're doing that. But unfortunately, that's the way it sits right now. And as we often say, if it's logical and fair, it probably was an accident.
Oh, great. Stacy asks, any feedback or tips for using modifier 59? Going a little off topic.
So the key to looking at modifier 59 in everything that you do is, number one, and first up, understanding the bundling rules as they sit. List a number of codes that are considered included in one another or part and parcel of one another. But you have to understand that those code pairs were established by having Medicare really take a look at how charges came in addition to maybe a few looks at the clinical approach. So understanding, first of all, that you're not going to use a 59 modifier if it's not part of a bundling edit or you haven't received a denial from a private payer if two codes have been billed together. Then the other part of this really goes back to what is part of the global and what's part and parcel of each one of the procedures you provide. So if you're providing a procedure or service in combination with another, and it is rarely or not often provided together, and the effort required is separate and really not part of the normal process, then you can think about using that modifier 29 or 59. So you definitely want to make sure that that the documentation and the thought process overall and the defensibility of this is, we are doing the second procedure for a medically necessary reason, and it is clearly not part of what's normally done. And then double check it against the bundling edits that you have. And if you're not worried about the denial, it's not on the bundling list, don't use the 59. But if it's on, then go ahead and use the 59 or the X modifiers, XE, XU, XS. And those are somewhat situational in the overall process. And then make sure your documentation supports exactly what your thought process is.
Sounds great. Now, for those of you who don't have access to the AUAcodingtoday.com's E&M calculator, not E&M calculator, more like the bundling matrix, it's a web-based software that you can access with a subscription, and you can put in all the CPT codes and place a service, and it'll automatically spit out which one you should list first, what kind of modifiers you can use, whether or not you can or cannot build these codes together. So AUAcodingtoday.com. Lisa asks if you could explain GPC1X again. I'm going to ask you to defer that because, Lisa, you will be able to watch it on the replay, and hopefully that will be sufficient. Or Mark, maybe you want to quickly give a highlight on GPC1X again.
So that what I'm going to tell you is a couple different things, and I'll expand a little bit on what I said in there. So the GPC1X in the proposed rule is an add-on code. It's to be billed every visit in which the patient has or being seen for an ongoing concern. So for urology, that's going to be a lot of your visits. The thing I'm going to add to this is, you can imagine that an add-on code of $15 to $20 for every single visit in which there's a chronic disease or a disease that requires an ongoing relationship is going to be a big cost to Medicare. And it's one of the reasons that the conversion factor is projected to go down. So there are some a number of groups who are being affected negatively by this new code that are pushing to have it further restricted or removed altogether for next year. So what I gave you was the information we have in the proposed rule. We are going to have to give you an update once the final rule comes out, which I understand is with the Office of Budget and Management. So that means we're probably only a few days away from seeing that released. So we'll have to see exactly what they decide and how it can be used. So what I gave you is what we expect, but we are not guaranteed. So you'll need to check back with us for the final utilization.
Yeah, I bet the final rule is probably not going to deviate too much from the proposed rule.
It's going to be interesting to see how we see what happens. There was a lot of lobbying from the surgical specialties, radiology, and anesthesia to block some of this because that's money out of their pocket going into yours, basically.
Yeah, it's the typical struggle among the specialties. Dr. Gupta asks, is TUR of a 2 centimeter, like 52234 or 52235? 52234 says up to 2 centimeters, and he basically wants to know, does it include 2 centimeters, as 52235 says 2 to 5 centimeters?
Yeah, it's an interesting one, but we would draw the line that if it's 2 centimeters, you would move to the medium. That up to 2 centimeters means until I get there, I'm in 4, but once I go to 2, I'm going to use 5.
So basically, 2 to 5 centimeters is 52235. Not if you have 1.99 centimeters, it'll be 52234. So that's the short answer. Marilyn asked a really, really nuanced and a great question on the 2021 E&M data portion. Does discussion of management or test interpretation with other qualified healthcare professional mean that a provider can discuss your dynamic results with an NP within the same practice? Does that count for category 3 data section?
So that's going to be that is an interesting question, and the answer is a little bit nuanced and unfortunately as we go. You'll also note as you look through that category 3 and the category 2 data says that the service was not separately reported. There's a possibility that we look at the interpretation, and if it was billed on a separate date and the interpretation was done on a separate date, that we might be able to count it. But there is also a possibility that we're not going to be able to count it if it's billed on a different date. If it was billed on the same date, I think there's no question we can't count that as medical decision-making data. So we've got a little bit of a gray area right now that we're watching if it's done on a separate date for that discussion. And then, of course, I'm definitely going to add in the mix that you're going to want to make sure it was medically necessary for that overall discussion and put that in to your documentation to count that. So it's a little bit gray if it was done on a separate date. And I would say if you're outside of, a week or two ahead of time, we're really talking about something that was done previously. Maybe there was another visit in there and now you're looping back to kind of close it. That one I would probably count for the time being until we can until we can get some clarification. But if it was done that week and that's part of the normal flow, I don't think I would. So it's a little gray.
Yeah, so basically we are assuming that this is an MP that's employed by the same practice, and then the doctor is talking to the MP regarding maybe the MP was the one who performed the urodynamic results. So this will go into the yellow light, not the green light where you can actually bill or count that in your E&M 2121 billing. This will be kind of like in the yellow gray zone, yellow light.
Exactly. And thanks for clarifying that, John. Yep, I was definitely assuming same practice.
Yeah. And if you are, for instance, I could outsource my urodynamics. It could be done by somebody else. And then if I were to call that person, that would count. It will be discussing the results. And I am not the one. Even though I ordered it, I did not bill for it, even though it is separately reported elsewhere, right?
Correct. Separately reported by your practice is what I should have clarified. You're correct.
Well, even the AMA documentation is not clear. It's just unless otherwise it's separately reported elsewhere. So it's not very clear until somebody explains it and interprets it, and you learn how to actually apply it. I mean, the rules are there, but understanding it and applying it, that's the hard part.
It is, and we'll be learning for a couple of years probably.
Oh yeah, definitely. So for those of for the practices that are, we're getting the warnings about possibly shutting down again. What words of wisdom do you have relative to telemedicine and how we should consider going forward in 2021?
Well, so, obviously as we, and I don't know if it's obvious or not, I guess I'm looking at it in a couple of different ways. So one of the things that we've heard is that the Moderna vaccine is potentially coming to healthcare workers in Colorado in the near future, which is going to be a good thing, obviously, but it doesn't mean that it's going to be widely available. So when I look kind of going forward with all the shutdowns, we may have it so that physicians and healthcare workers are kind of fairly safely back out and fully functioning, where we don't have everybody else doing the same. So I do think you're going to need to prepare to adapt and adopt that telehealth because of the patient's fear or because they're actually shut in. So being able to, again, leverage telehealth across the board is going to be key. And for those of you who have been able to, and John, I know you're one, that have continued to use telehealth intermittently, even though your practice is open, you've got some practice in what they're doing. But if now that everybody's had a little bit of experience with it, build your office flows up so that, you can have somebody from your staff, perhaps work the patient through all of the technical difficulties, get everything set up so that you as a physician can practice at the top of your license, not as a Microsoft support team, and get on with the patient, use the time that's focused with the patient to provide them the care that they need. The more you can get that as built into part of your routine, even if it's a short window every hour or whatever you do, the better off you're going to be. I went over the guidelines as far as what we're doing with public health, the public health emergency. Keep using the E&M codes. When we get outside the public health emergency, we're going to have to reassess what we can and can't do. But I tell you, the patient demand is there. So I think there's going to be some changes coming down the pipe for telehealth, even outside the public health emergency. But while the pandemic is raging, you definitely go ahead and use those and use them. Count your time as you need it, but you can use the current guidelines really right now, which still doesn't require a history and physical. It's all medical decision making. And then of course, next year, all of our office visits are going to be based on medical decision making or time. So
I don't know if everyone caught that. For telemedicine during the public health emergency for Medicare patients, you currently, right now, today, you do not need to document history of physical examination for billing purposes. So medical legally, yes, you want to document whatever is necessary, but for billing purposes, today, not 2021, today, for telemedicine, you do not need to document history of physical examination. Everything is driven by medical decision making. All right, number two, when you mentioned, Mark, you mentioned that it is insinuated that it is less efficient to bill based on time. And I will give you my example. For my telemedicine visits, and I'm doing about 12 this afternoon, I chunk my telemedicine visits at the end of the day, and I'm doing them every 10 minutes. So just something that you all can think about doing. When it comes to preparing the charts for telemedicine, it is similar to in real life type of a visit. I have my staff prepare the chart, and then the only thing that I do is open up the chart and dive right in as soon as the patient is on my screen on the telemedicine platform. So it is extremely efficient. And once you're out of the public health emergency, you want to think about, well, some of my patients may still want to continue with telemedicine. Some of your patients may be too far away to come visit you. And do you really need to see these patients? To say, for me, if I have to drive 30 minutes, 45 minutes to see a specialist, and if I can do that remotely, I would pay cash because my time is valuable. And I bet a lot of your patients would think the same. So you need to start thinking about beyond the current public health emergency when it comes to telemedicine, because it's like sex, orgasm, and high-speed internet. Once you experience it, you can never go back.
I would totally agree. And I do think as we've started exploring, and we were exploring this quite a bit before the public health emergency, the opportunities that are available to you from a lower cost outreach, maybe not a reimbursable event, but to actually make your office more efficient, those are available too. So you may have opportunities not just on cash-based encounters, but on group discussions. And I mean, there's a lot of things that you can do to turn around and focus your office life based on getting the patients the care that they need and your efficiency in providing that. So I think we got to start thinking outside the box and take advantage of the fact that just about everybody knows how to use Zoom now.
Yeah, and also, so what I did recently was I emailed a bunch of my BPH patients who never had a TURP, who never had a Urolift, and then offered them a webinar. So it's already a warm audience, and I had a lot of responses. It's a free Zoom type of a webinar that I presented, and I was able to get a lot of these guys to come in to have a definitive treatment, and then they're off my rolls. I've cured them so they don't have to keep coming back. And I can make more room for new patients.
Exactly what we need to be doing.
Yep. All right. We only have a few minutes left. I'm going to give Jessica last few words. And before we conclude, Mark, I know we have an upcoming webinar, December 4th and 5th, the Urology Advanced Coding Reimbursement Seminar. Can you give us a little bit more information about that?
Yeah, happy to, John. And yeah, we're really trying to leverage Zoom and to put all this information together. And we've got, obviously, John's going to join us. We've got Larry and we're going to be covering, and Scott, and we're going to be covering a lot of information, the new E&M codes in detail, going over modifiers. We're going to spend a lot of time going over scenarios. We're going to use breakout rooms to increase the interaction back and forth. So we're really going to make it as much live as we can and leverage the technology that we have to build interactions between and among us and everyone who attends. So there's a lot of information that's here, a lot of prep work, really try and bring you in to what you need to kind of get prepared for next year. We're going to talk about telehealth and how to leverage that. So we got a lot of topics to cover. It'll be a full 2 days. And really, hopefully, we're designing it to be very interactive. We want everybody to join, use their cameras, and really be a part of it, because we learn a lot from each other. And not having that ability to get face to face and have that exchange, we've got enough improvements in Zoom and some of these meetings that we can recreate at least a portion of that to rebuild the community we have within PRS. So we'd love to have you join us.
Yeah, definitely. In the years that I've attended some of the best information, sources of information, inspiration, and thinking out of the box come from practices who are actually attending there, and they are doing things that you never even thought of, or using codes in a novel way that makes you think, that may be a good idea, or that may not be a good idea. So looking forward to seeing everyone on December 4th and 5th, and it is actually tagged in the announcement section of the Thriving Urology Practice Facebook group. So thank you again, Mark, for this awesome presentation.
Thank you, John. I always appreciate talking to you and your phenomenal moderating skills. You're a master. Thank you.
You're too kind. And I'm going to leave the final word to Jessica Pompa. She's part of the market development team for Feargene. And here's Jessica.
I would just like to say thank you for tuning in. Thank you for setting this up, Dr. Lynn. Thank you, Mark Painter, for all your expertise. I'm proud to work for a company that's providing these valuable programs for the urology practices, and I hope this shows our commitment to urology and really, forging ahead, creating these innovative solutions in bladder cancer, but also providing these resources. If you'd like additional information on Feargene, I believe Dr. Lynn will drop in my contact information. Feel free to email me. I can answer any questions you may have, and thank you again.
All right, everyone. Any comments or questions? As usual, leave them below. Have a great afternoon. Bye-bye.